Acid-base balance is the result of processes that carefully regulate hydrogen ion production and elimination. Body fluid pH is a measure of the body fluid's free hydrogen ion level. This value has the narrowest range of normal and the tightest control mechanisms of all the electrolytes. The level of free hydrogen ions formed from acids must be rigidly controlled for proper function. Even small changes in the free hydrogen ion level or pH of body fluids can cause major problems in function. Keeping the pH within the normal range involves balancing acids and bases in the body fluids. Acid-base balance occurs by matching the rate of hydrogen ion production with hydrogen ion loss. After this lesson, you should be able to use laboratory data and clinical manifestations to determine the presence of acid-base balance. Interpret arterial blood gases to determine whether acidosis is respiratory or metabolic in origin. Prioritize nursing care for the patient with an acid-base imbalance. And explain the concept of compensation. Acid-base imbalances are changes in the blood hydrogen ion level or pH. These changes are caused by problems with the acid-base regulatory actions and mechanisms of the body or by exposure to dangerous conditions. Imbalances in which blood pH is below normal reflect acidosis, and imbalances which blood pH is above normal reflect alkalosis. Acid-base imbalances impair the function of many organs and can be life-threatening. So first, let's discuss how to interpret ABGs. Do you know what ABGs are? Correct. ABGs are your arterial blood gases. So being the investigator, the first step in interpreting ABGs is to assess the pH. What is normal arterial blood pH? That's right, 7.35 to 7.45. So anything below would be acidosis, anything above would be alkalosis. So the next step is going to be to assess the respiratory component, partial pressure carbon dioxide, also referred as PaCO2. Normal range is 35 to 45. Increases indicate respiratory acidosis. Decreases indicate respiratory alkalosis. Okay, Inspector, the next thing we want to do is assess the metabolic component, the bicarbonate, also referred to as HCO3. Normal range is 21 to 28. Increases are indicative of metabolic alkalosis. Decreases are indicative of metabolic acidosis. Step 4, number 2 and number 3 should provide us with the information whether the situation will be compensated or uncompensated. And the last step of interpreting ABGs is to identify whether the situation is chronic or acute. It seems like it's a lot to grasp, doesn't it? Actually, acid-base imbalances and ABG interpretations can be quite simple once you understand the different imbalances and the formulas for interpreting. Acidosis can either be actual or relative. Actual acid excess results in acidosis by either overproducing acids or under-eliminating normally produced acids. Relative acidosis is the result of the amount of acid not increasing, but the amount or strength of the bases decreasing. Understanding acidosis. In acidosis, the acid-base balance of the blood and the other extracellular fluid is upset by an excess of hydrogen ions. This problem is reflected as an arterial blood pH below 7.35. Acidosis can be caused by metabolic problems, respiratory problems, or combined metabolic and respiratory problems. Specific causes of acidosis are listed in Table 14-2, page 203 of your textbook. I'm going to discuss some key features of acidosis and the effects on each bodily system. In the central nervous system, the patient will exhibit depressed activity such as lethargy, confusion, stupor, and/or coma. In the neuromuscular system, the patient may exhibit hyporeflexia, skeletal muscle weakness, and/or flaccid paralysis. In the cardiovascular system, the patient may exhibit delayed electrical conduction ranges from bradycardia to heart block. You have tall T waves, widened QRS complexes, and/or prolonged PR intervals. The patient may also exhibit signs and symptoms of hypotension and/or arthritic peripheral pulses. Respiratory manifestations can include small respirations, especially in metabolic acidosis with respiratory compensation, and variable respirations, generally ineffective in respiratory acidosis. Then we have the integumentary system. The patient may exhibit warm, flushed, dry skin in metabolic acidosis and pale to cyanotic and dry skin in respiratory acidosis. Chart 14-4, page 204 of your textbook provides you with key features of acidosis. Okay, so let's discuss metabolic acidosis. The four processes that can result in metabolic acidosis are overproduction of hydrogen ions. Some examples would be hypermetabolism, ingestion of acids, and/or excessive oxidation of fatty acids. Another process would be under-elimination of hydrogen ions. An example would be during kidney failure. Another example could be underproduction of bicarbonate ions. Some examples could be kidney failure, pancreatitis, liver failure, and/or dehydration. And the other process would be over-elimination of bicarbonate ions. Some examples could be through diarrhea and/or buffering of organic acids. Some collaborative care would actually include to administer fluids as prescribed, administer insulin and fluid hydration, prepare the patient for possibility of dialysis, institute seizure precautions, monitor ABGs, maintain a patent IV, monitor tissue oxygen delivery, and monitor bicarbonate loss. So then you wonder, during metabolic acidosis, how can you tell if it's compensated or uncompensated? Well, let's discuss interpreting ABGs for metabolic acidosis and determining the compensation. The key indicators for compensated metabolic acidosis are the pH will be normal, the partial pressure carbon dioxide will be decreased, the partial pressure oxygen level will be normal, and the bicarbonate will be decreased. Now, for uncompensated metabolic acidosis, you will see a decreased pH, a partial pressure carbon dioxide either being normal or decreased, partial pressure oxygen being normal, bicarbonate being decreased, and an increase in potassium. Okay, now we're going to talk about respiratory acidosis. In respiratory acidosis, we have a reduction in the exchange of oxygen and carbon dioxide. So think about this for a minute. Which of the two increases between oxygen and carbon dioxide? And what is the result of this increase? And then how many mechanisms for respiratory acidosis? Your key concern will be to maintain a patent airway and enhance gas exchange. You may need to use drug therapy to increase the diameter of the upper and lower airways and to thin pulmonary secretions. We may also need oxygen therapy, pulmonary hygiene, ventilation support, and we want to prevent complications. Okay, so let's discuss compensated and uncompensated respiratory acidosis. In compensated, the pH will be normal. The partial pressure carbon dioxide will be increased. The partial pressure oxygen level will be decreased. And the bicarbonate level will be increased. Now, uncompensated, the pH will be decreased. The partial pressure carbon dioxide will be increased. Your partial pressure oxygen level will be decreased. And your bicarbonate will be normal. In patients with alkalosis, the acid-base balance of the blood is disturbed and has an excess of bases, especially bicarbonate. Some of the listed causes, but not all of the causes, of alkalosis are hyperaldosteronism, thiazide diuretics, actual alkalosis, oral ingestion of bases such as antacids, parenteral infusions such as blood transfusion, bicarbs, or TPN. And then we have relative alkalosis, is like a decrease in the number of acids. Could be due to prolonged vomiting, nasogastric suctioning, or hypercortisolism. Okay, we're going to talk a little bit more about alkalosis. Remember that clinical manifestations are the same for metabolic and respiratory alkalosis. In the CNS system, the patient will exhibit increased activity, anxiety, irritability, tetany, seizures, positive Shavastic sign and positive Trousseau sign, and paresthesia. In the neuromuscular system, the patient may exhibit hyperreflexia, muscle cramping and twitching, and/or skeletal muscle weakness. In the cardiovascular system, the patient may exhibit increased heart rate, normal or low blood pressure, and/or an increased digitalis toxicity. And then the respiratory manifestations can include an increased rate and depth of ventilation in respiratory alkalosis and/or decreased respiratory effort associated with skeletal muscle weakness in metabolic alkalosis. Chart 14-6, page 208 of your textbook will provide you with key features of alkalosis. So our collaborative care for alkalosis is going to include to prevent further losses of hydrogen, potassium, calcium, and chloride, restore fluid balance, monitor fluid and electrolyte levels, and medications that can be used to resolve the causes are fluid and electrolyte replacement and antiemetics. Metabolic alkalosis is caused by any condition that can create the acid-base imbalance through either an increase of bases or decrease of acids. Causes can be due to excessive use of oral antacids or during medical treatments. Okay, so we're going to talk a little bit about compensated and uncompensated metabolic alkalosis. In compensated metabolic alkalosis, it will include a pH to be normal, a partial pressure carbon dioxide to be increased, a partial pressure oxygen to be normal, and the bicarbonate to be increased. In uncompensated metabolic alkalosis, this will include a pH to be increased, the partial pressure carbon dioxide to be normal and or increased, and then the partial pressure oxygen to be normal, and then bicarbonate to be increased. In respiratory alkalosis, this is a result of excessive loss of carbon dioxide, hyperventilation usually caused from fear, anxiety, mechanical ventilation, or ciliate toxicity. And then we have hypoxemia, is stimulated hyperventilation such as through high altitude shock or early stage acute pulmonary problems. Compensated respiratory alkalosis will include a pH being normal, the partial pressure carbon dioxide to be decreased, the partial pressure oxygen to be normal, and bicarbonate to be decreased. Now, uncompensated respiratory alkalosis will include a pH to be increased, partial pressure carbon dioxide to be decreased, partial pressure oxygen to be normal, and then bicarbonate to be normal. Okay, interpreting ABGs made simple. Anytime you interpret ABGs, you need to write down your information to make it simple and safe. The first step will be to set up an acid-base line. The left end of the line represents acid or acidosis. The right end of the line will represent a base or alkalosis. So the first step interpreting ABGs would be first to review your pH. Is it acid or base or normal? The amount represented for your pH will be the determining factor. Even if the pH is normal between the ranges of 7.35 to 7.45, you will use the 7.40 as the focal point of your line. So any pH below 7.40 will be considered an acid, and any pH above 7.40 will be considered a base, even if the pH still falls in normal range of 7.35 to 7.45. Then you will place your partial pressure carbon dioxide. Enabled to match the appropriate side of the acid-base line, you will place your ranges to indicate 45 being on the acid side end of the line and 35 being on the alkalosis side or base end of the line. Then you review your bicarbonate, 21 being at the acid end of the line and 28 being at the base end of the line. If both the partial pressure carbon dioxide and the bicarbonate are abnormal, that means there is an indication of compensation. You want to also remember that partial pressure carbon dioxide represents the respiratory and bicarbonate represents metabolic. Okay, so let's do an example. I have a pH of 7.38. A partial pressure carbon dioxide of 49, and a bicarbonate of 32. Now to look at this, my pH is normal but is closer to the acidic side of the line. So I have an acidic situation. Since I have an acidic situation, I must choose between the bicarbonate or the partial pressure carbon dioxide. Which one's closer to the acidic end of the line? Correct. The partial pressure carbon dioxide is at the acidic side of the line. Therefore, I have to go with the partial pressure carbon dioxide, which indicates this is not only is an acidic or acidosis situation, but it is now also a respiratory situation. So I have respiratory acidosis. Now, how can I tell if it's compensated? Well, the bicarbonate is abnormal and closer to the base or alkalosis end of the line. This tells me the metabolic system is working harder, increasing the base, attempting to balance the acid-base imbalance, and since the metabolic system was able to bring the pH back into normal range, this would be considered compensated. So our end result is compensated respiratory acidosis. This concludes Acid-Base Imbalances lesson. If you have any questions related to lesson content, contact the instructor. There is a YouTube video provided in the lesson area on Blackboard in this content for you to review some easy techniques for ABG interpretation.